person and online. Got a really good programme for you today. We've got a really diverse audience. So joining us today are people working in primary care, GPs, we've got physicians associates, got pharmacists and CNSs. So a really great audience here with us. So today we're here really to discuss early diagnosis of haematology cancers. So we're here to try and work across our system boundaries between primary and secondary care, as well as our professional groups, really for our patients who might have a diagnosis of blood cancer. How we can diagnose them earlier and bring them into the system so we can treat them sooner before we have complications and problems. So today we want to make sure that we're really bringing the patient voice to the front of everything that we do here in Greater Manchester Cancer. So interspersed with all of our presentations, you'll hear talks from patients speaking about their journey, what this meant to them, about their diagnosis and how they were feeling throughout their experiences. So I want to get started. I'm sorry we started a little bit late today. So this is our first patient. This is Liam and this is his story.
Hi, my name's Liam, and I was diagnosed with acute myeloid leukemia in September 2020. I'd had what I know now were some symptoms of it for a couple of months beforehand. I used to run quite a lot, so I was getting shortness of breath, and I did stop running. And I was just feeling really fatigued and run down. I think I spoke to the GP on the phone a couple of times, maybe 3 times over the course of a couple of months, just to say that I was feeling short of breath and that I couldn't run as far as I used to be able to. But because it was during lockdown, I think we sort of just assumed it might have been because I was putting weight on or just wasn't exercising as much, so that's why I was feeling fatigued. And I do have asthma, so the GP gave me a new inhaler and increased the amount of time that times a day I should take the inhaler. And yeah, just feeling generally fatigued and not really having any energy, and this got worse. But I ended up going to A&E because I was having sort of pains in my chest and sort of in my neck. Again, because it was lockdown, I couldn't get a GP appointment about this, and I think the GP would have probably said to go to A&E with pains in the chest anyway. It just felt like an indigestion type pain to me. Yeah, I went to A&E Friday afternoon. All my temperature, heart rate and everything like that was fine. I was expecting to go home, and then the blood counts came back and the neutrophils were like 0.0 something. So then I got kept in. That was a Friday afternoon. I was kept in over the weekend. Did a bone marrow biopsy on the Monday, and then on the Tuesday I got told that I had AML. It just felt surreal, really odd. For doctors and nurses that I'd never met before, I was just obviously in a room on my own. Couldn't have any visitors because of COVID, and yeah, just had to ask a couple of times if I had cancer, and yeah, just had to just sit and process it really. So the original plan was that I would have 2 courses of chemotherapy to see how I responded to them, and then maybe have a stem cell transplant. So I had 1 set of chemo straight away, then another one, and at that point I was told that I didn't need to have the stem cell transplant, which was obviously really good news. And then I was due to have my 3rd round of chemo actually the day before I started the third round of chemo, I got a call to say that a bone marrow biopsy had shown that the leukemia had been found at a molecular level, so they did want to do the stem cell transplant. So that was probably one of the hardest parts, because I had to go in and have intensive chemo for however long it was, 4 or 5 weeks, and then I needed to complete that section of chemo. So then I had to have a 4th round of chemo before I could come out, and then have a 5th round of chemo before I actually had the stem cell transplant. So I had the stem cell transplant in April 2022, and I was in hospital for about 8 weeks then. And yeah, it was just really intense and really difficult, but I feel quite lucky that I was diagnosed in September, and by the end of sort of May 2021, I'd gone through all of the chemo and had the stem cell transplant, and touch wood, I haven't been back in hospital since then. So what I think good care looks like for someone with a haematological cancer, or spotting the signs of a blood cancer, is just, when I initially got in touch with my GP, I think if there'd been some more explorative questions to maybe try and join the dots up, and get to my diagnosis sooner. So on hindsight, looking back, I was having really bad night sweats for a couple of months before I went to A&E and got diagnosed. I was also having like weird angry spots on my thighs, and they were sort of getting infected and just lasting for a little bit longer. And I think if I'd been asked if there was anything else on my body, or if I'd noticed anything else different, I think that, coupled with crucially getting a blood test done, I might have been able to, or the GP might have been able to join up the dots sooner. And I know when I was on a ward with people in hospital, there was about 4 or 5 people who, at various points, I got put in a ward with, who were around about my age, and they all had similar stories of going to the GP and not having blood tests done. I remember there was one guy I spoke to, and he kept getting throat infections or ear infections, and he was on a few courses of antibiotics, and it ultimately led to a leukemia diagnosis, but because blood tests weren't done at the time, he didn't know about that. And just the general fatigue and night sweats just seem to be something that has happened in everyone that I've had exposure to, really. So yeah, I think, yeah, that those would be warning signs for sure, or anything that just doesn't seem quite right. And fundamentally, I knew for a couple of months there was something not right with my body, and I think it's important to try and find out what is wrong when someone knows, like I did, that essentially something wasn't quite right.
Okay, thank you. So that was Liam's story. He's one of our patient user representatives on our Haematology Oncology Pathway Board. These videos were made with the help of the user involvement group at Manchester Cancer. So if anyone's got any feedback about them that they'd like to give the patients, would love to hear what you think about these patient story videos. So Liam was obviously diagnosed after attending accident and emergency, which is very common for some of our haematology cancers. We're still having over 40% of our patients diagnosed through emergency presentations rather than through a primary care visit. So that's really one of our aims from today, is if we can raise awareness of our cancers and how they present, it might just trigger something in people's minds to think about blood cancers sooner, and then we can try and prevent these patients coming to hospital for their diagnosis. It's very important for some of our cancers. For example, in myeloma, it really does affect your 1 year and 5 year survival if you're diagnosed via primary care versus having to wait and come as an emergency presentation. So moving on to our agenda, we're a little bit behind time today. Our first presentation is going to be from Charlene and Lindsay from the Teenage and Young Adult Centre at the Christie.
Thanks, Suzanne. Thank you. Good afternoon, everybody, and thank you to GM Cancer and the Pathway Board for inviting us to speak today. My name's Charlene Jones. I'm the Teenage Cancer Trust Senior Clinical Liaison Nurse Specialist for Greater Manchester and North Cheshire, and I'm based at the Christie, and this is Lindsay.
Hi, I'm the Senior Teenage and Young Adult Clinical Nurse Specialist based at the Christie.
So, oh, that's not the first one.
Hi, my name's...
Thanks. So just a very brief overview of what services are available in the North West for teenagers and young adults, which some people in the room may be aware of. So we're very well served for 16 to 24-year-olds in the North West. We have a dedicated principal treatment centre at the Christie Hospital with a dedicated unit for 16 to 24-year-olds with outpatient, inpatient and ambulatory care facilities. But also it's recognised that young people are such a unique group and they require specialist services, but also the older age range sometimes want to be treated closer to home. So there is a service which is the outreach service, which I lead for 19 to 24-year-olds. So that means they get to stay in their local hospitals, some of your own local hospitals, so that they can have equity of care with young people at the principal treatment centre as well. So in talking about young people, we need to define adolescence. So it can be considered as one of those transitional stages from childhood to adulthood. It's a time of disorientation and real discovery and a major stage of development for young people. And it's a really complex time of life, which embraces elements of biological growth, physical growth, psychological and cognitive development. And it's second only to that period between conception and birth. So cancer really challenges the developmental tasks and stages of a young person's life and often leads to crisis and an inordinate struggle with those developmental tasks. So we see about 2,500 to just under 2,500 young people every year diagnosed with cancer in the UK, and that's 16 to 24-year-olds. 7 young people are diagnosed every day in the UK, and in our region, in Greater Manchester and Lancashire, that equates to about 150 to 200 young people each year. But they only represent less than 1% of the overall cancer population in the UK. It's a leading cause of death after road traffic accidents in this age range, and cancer peaks at about 20 to 24 years of age. Now, the rates have increased since the 1990s by about 24%, but we're not entirely sure, it's not clear whether that's actually due to more robust data collection rather than actual cases increasing. So the 5 most commonly diagnosed cancers, this is a piece from Cancer Research UK. So this table depicts that. I don't know if you can see because it's quite small, sorry. But males aged 15 to 24 account for 21% of lymphoma cases compared to 10% for leukemias. And then females aged 15 to 24 account for 20% of lymphoma compared to 8% of leukemia. And lymphoma is the most common cancer in young people. There is a larger bar just there, but that is a combination of carcinomas and melanomas. So it's clear that cancer is really rare in this age range, and it's further complicated by a unique spectrum of cancer types with both paediatric and adult type tumours and a variety of different symptoms. And as GPs and primary care providers, you may only see 1 or maybe 2 young people who go on to develop or go on to be diagnosed with cancer in your whole career. So therefore prompt diagnosis and referral can be really difficult. Young people often fall between child and adult health disciplines, and then cancer is often misdiagnosed in this age range. There's a major study which has been ongoing for a couple of years now, the Bright Light study, looking into the experience of young people with cancer aged 12 to 24. And that found that 40% of young people have 3 or more GP consultations prior to onward referral, compared to 20% for the over 35 age range. There's quite a disparity, really. Symptoms are often put down to stress, anxiety, mental health, sporting injuries. So there's a real need for more awareness and more campaigns around primary care to be able to update people really and educate people. Young people often have convoluted and prolonged pathways as well compared to children and older adults, and consequently diagnostic experience is listed as one of the top 5 research priorities for teenagers and young adults and professionals in the UK. The 5-year survival rate, move on a little bit. 5-year survival rate for teenagers and young adults is between about 50 and 98% in high-income countries, depending on which cancer type. But improvements in this range have been really, really modest over the last 20 years, especially in solid tumours, not so much in haematological cancers. But there's a real disparity in long-term survival compared to adults and children. And the biology and clinical behaviours of cancers in this age range really differ due to their specific molecular features, and they're often poorly misunderstood. And also a young person's pharmacological response to therapy can also be different in this age range, and that causes less favourable outcomes sometimes. Protocols often aren't tailored to their age range, and clinical trials are not widely available for this age range either, because of them falling between that gap between child and adult care. And engagement from young people is limited from a clinical trials point of view as well. Lifestyle risk factors have probably a less significance in this area, but evidence of this is limited, and this is mainly because of the relative rarity and diversity of the cancer groups. Although young people's lymphoma risk may relate to certain infections, but again, evidence is unclear. But what is clear is that there's a real need for a multidimensional and multi-professional approach to these young people.
So, as previously highlighted, adolescence is a period of major change and development. Being told they have cancer and potentially a life-threatening illness can send a young person into turmoil with a complete lack of control and create a crisis of identity. Whilst a cancer diagnosis is a major life event for any age, it can be particularly disruptive to a young person's life. From a biological perspective, numerous physical changes are taking place during this time, and this can be further compounded by treatment. So the young person can experience image-altering side effects from surgery or the treatment, experience hair loss, lose or gain weight, lose physical fitness. Fertility can be affected, either complete loss or early menopause. Cognitively, we know that the brain doesn't fully develop until the age of 25. So thinking, making decisions, processing a diagnosis and coping psychologically can be different for the young person. Socially, the teenage and young adult is kind of beginning their separation away from parents into independence, gaining a strong reliance on peers. A cancer diagnosis can mean that they can become isolated from their friends, become more reliant on family, feel different from their peer group. School or work can be disruptive or disrupted, which can have a long-term impact on kind of career or education development. All of this combined can lead to reduced confidence, an altered sense of self, anxiety, depression. So the tasks of adolescent development may take precedent over other demands, such as medication regimens, clinic visits, and lifestyle decisions, which actually can impact on compliance with treatment and their outcomes. So looking at route to diagnosis for the young person, this piece of work was carried out by Macmillan, and we see that 17% of cancer cases in young people in England were diagnosed via the 2-week referral route, compared to 28% of 25 to 49-year-olds. Around a quarter of the cases in young people in England are diagnosed after presenting as an emergency, compared to just 13% in the 25 to 49 age group. Just over a quarter are diagnosed following a routine or urgent GP referral. So looking a bit closer, this graph shows the distribution of diagnostic routes for the teenage and young adult patient by diagnosis and gender. So we've just highlighted the lymphoma and leukemia as focusing on haematology. So as you can see in this, the GP referral and 2-week wait for lymphoma is more than double than the GP referral and 2-week wait for leukemias. Male leukemias diagnosed via emergency was 62% compared to the male lymphoma at just 24%. And again, this is similar for the females. So the female leukemia, 54% was diagnosed as an emergency compared to just 21% of lymphoma. this could be explained by the, the acute nature of the leukemia compared to the lymphoma presentation. So we've just got a video here from one of our young girls that was diagnosed last year. She's just talking through her route to diagnosis and how this has actually impacted her experience of treatment. Go back.
Do you want us to go back to the beginning? No.
Hi, my name's Phoebe. I'm 23 and I'm a law student at the University of York. And in January 2022, when I was 21, I was diagnosed with T-cell acute lymphoblastic leukemia. I first noticed something wasn't right in the October before my diagnosis when I took myself to A&E with some chest pains and chest tightness that I was having, and they ran some blood work there and told me that I had an infection and to go home and rest, which I did, and it got a bit better. But after that, I was constantly feeling fatigued. I had no appetite, so I was losing quite a significant amount of weight, and that was for the November, and it became really quite prominent while I was home over Christmas. I know my mum was worried about my weight, and then I went back to uni in the January, and that's when I started making appointments with my GP. I made multiple appointments for multiple issues that I was having at the time, and for each appointment I saw or spoke to a different doctor at the practice that I was registered at. I had an appointment for a cough and a crackle in my chest that I'd been experiencing for a few weeks, and that became a telephone appointment where I was prescribed an inhaler over the phone. I had a separate appointment for some severe stomach pain that I was having. I was in a lot of discomfort over one weekend and made an emergency appointment on the Monday. I had an appointment with one doctor for that. I had a separate contraceptive pill review for some ongoing unmanageable menstrual bleeding that I was having that had been going on for a couple of weeks and just hadn't stopped. And then they had booked me in eventually for some blood tests I think they couldn't fit me in for about 2 weeks. And then I had an injury during a netball match, which led me to take myself to back to A&E, because it happened very easily. I was feeling very unwell. I was covered in bruises. I was covered in a dotted petechial rash. I'd lost about 8 kilograms without really trying to, because I couldn't eat, and I was having night sweats. So I took myself to A&E where I had an x-ray on my arm, and I saw an on-site GP there as the triage nurse decided that there was something wrong with the clotting in my blood. And the doctor there told me that I was booked in for a blood test at my GP in a couple of weeks, and just to wait until then. The following day, I began to feel really, really unwell and had no energy, was absolutely head to foot in bruises, couldn't control my bleeding. We knew that I needed a blood test, but I couldn't get one in the local A&E or with my GP. So I went back home to Manchester, where my mum's friend had a contact with a phone number for my old GP, and we contacted him, and he got me in and ran some blood work. And that evening I received a phone call telling me that they were 99% sure I had leukemia and to make my way to MRI. I think the way that my diagnosis happened has had quite a significant impact on the way that I have been throughout my treatment. I am definitely very, very anxious. I think it's inevitable that I would be no matter what, but the way that I was diagnosed and the way that I had to advocate for myself and Google my own symptoms and repeatedly take myself back to see GPs or to A&E telling them that something was wrong and being dismissed a lot has made me very sort of hyper aware of what's going on in my own body, and it made it quite hard for me to trust the doctors at first, that they were making the right decisions or they were listening to me and that they were really hearing what was wrong, which this has improved over time as I've been treated, and the medical care has been exceptional, which has helped with this a lot. But I think I've been left with a lot of anxiety, which I am having to manage. I think that there's a few things that could have been handled better on the lead up to my diagnosis. Seeing different doctors for the different issues that I was addressing didn't seem very beneficial. I think that if I had seen one GP and we'd gone through all of my issues and investigated them, there is a much more likely chance that we would have led to this diagnosis sooner. I also think the telephone appointment for my cough and the crackle in my chest wasn't great, because obviously over the phone no one was actually able to listen to my chest. And I also think that rather than booking me in to have blood work done in 2 weeks' time, it would have been better if someone could have just taken my blood there and then I wouldn't have had to take myself to A&E a couple of times in the hope that that would have been done for me.
So, as we can see, Phoebe's route to diagnosis massively impacted on her treatment moving forward. And evidence does show that young people who take longer to be diagnosed with cancer are more likely to report poorer patient outcomes, have a higher risk of impaired quality of life. There's clinical anxiety and clinical depression 6 months post-diagnosis is higher. We see a lack of trust within the healthcare teams, and they report a poorer experience of care.
So there are many types of blood cancers, but the ones we're going to focus on today are particularly leukemia and lymphoma, because they're the most prevalent in our young people. So Hodgkin lymphoma is the most common in cancers, as we've said, and around 2 in 3 young people diagnosed with lymphoma have Hodgkin lymphoma. Most have classical Hodgkin's lymphoma, the most common being nodular sclerosing, and up to 1 in 10 young people have the less common type called nodular lymphocyte predominant Hodgkin lymphoma. There's also non-Hodgkin lymphoma, and around 1 in 3 young people are diagnosed with this. There's lots of different types of non-Hodgkin lymphoma, as illustrated here. The different types are usually grouped together depending on how they behave. Most non-Hodgkin lymphoma are in young people are high grade, but generally they're very well treated. So that would be diffuse large B-cell and Burkitt's lymphoma. So another further study carried out by Bright Lights, the Bright Lights trial found that a cohort of about 260 patients studied 260 lymphoma patients, TYA patients, and these were the most common 10 most common symptoms which they presented with in GP to primary care. Around 45% of young people report 4 or more presenting symptoms, and the top 5 being the ones in the first table, which are a lump, lymphadenopathy, extreme tiredness, night sweats, and weight loss. More than 50% of patients with lymphoma or leukemia are likely to report multiple symptoms. It's important to say sometimes these symptoms are can be non-specific as well when they present in primary care, but often a young person would present with painless, non-tender, firm, rubbery cervical or supraclavicular lymphadenopathy. Sometimes a cough and chest symptoms as well, suggestive mediastinal involvement. Patients are often present with B symptoms in this table here, which are associated with increased plasma levels of inflammatory proteins, including CRP and cytokinin, such as interleukin-6. And some of these symptoms include unexplained fever, itch, drenching night sweats, and more than 10% weight loss. A very urgent referral for specialist assessment for lymphoma in a young person with unexplained lymphadenopathy and splenomegaly should be considered. And also associated B symptoms or shortness of breath, and something we see quite a lot in young people is alcohol-induced node pain as well.
So leukemia, obviously cancer of the white blood cells. The four main types of leukemia are as shown: chronic myeloid leukemia, acute myeloid leukemia, chronic lymphocytic leukemia, acute lymphoblastic leukemia, and acute lymphocytic leukemia, So another type of leukemia as well that's less common is hairy cell leukemia. So each disease has its own characteristics and treatment. So it's named according to which type of blood cell that it is affected and whether it's chronic or acute. So the acute leukemias we see coming on suddenly, often within days or weeks, sometimes months, and progressing quickly and needing to be treated urgently. Chronic leukemias develop more slowly, often over many months or years, and sometimes they can be picked up incidentally. So leukemias consist of about 10% of all teenage and young adult cancers, with ALL more prevalent in the TYA age range than AML. So when looking at the outcomes for the TYA patient, they're worse than pediatrics for both AML and ALL. When exploring kind of the reasons for this, we can consider the role of the distinct genetic and biological features of the disease at different ages, the effects of social and behavioural factors, toxicity profiles of the treatment, adherence to therapy, and also the clinical trial recruitment. We see better outcomes for those on trials than those not. So, as we noted earlier, there's been an increase in TYA cancer since the 1970s, and this is still continuing to rise. We're seeing this as well with the leukemias, and this is unexplained, but is due to the consistency across age, sex, geographical region, it's presumed to be a real increase. Again, the Bright Light study was looking at the most common presenting symptoms for leukemia, which again we can see in this table, the top four kind of presenting symptoms being extreme tiredness, headaches, bruising and bleeding issues, and weight loss. And as Charlene said earlier, more than 50% of patients are likely to present with reporting multiple symptoms. So just looking at the symptoms of AML and ALL, some of them are quite similar. They're symptoms related to the bone marrow failure, acute presentations usually occurring within weeks, fatigue and infection being really common. Neurological symptoms can include headache, seizures, So again, with those symptoms, we're considering an urgent referral for a full blood count, usually within 48 hours. So when the young person's been diagnosed with their cancer diagnosis and have completed their treatment, they'll enter into a phase of surveillance and long-term follow-up, which will be shared between the treating centre and often the primary care services. The aim is for every young person to be given a treatment summary, which will outline their treatment history and any follow-up required to be completed, supported by primary care. Treatment can cause a variety of long-term side effects, of which it's important to be aware of. So this slide illustrates some of the main long-term effects of the specific treatments. The treatments for leukemia often include a large amount of steroids, which puts the young person at particular risk of osteonecrosis moving forward. And another really big consideration for our young people going through treatment for cancer is the effect on their fertility. This is especially pertinent because they're likely to be at the early stages of their reproductive journey. we strive to ensure that every young person gets a referral through to fertility services. However, this doesn't always result in cryopreservation occurring. Barriers to this can include, for example, with the acute leukemias, it's really urgent to start treatment really quickly, and for girls to harvest their eggs it can take a few weeks, and we often don't have time for them to complete this. Sometimes for the boys, if they've presented really acutely unwell, there's an inability for them to actually provide a sperm sample. And even after treatment, even if they have preserved prior or not, they're often wondering what their fertility status is after that. So every young person is able to be referred for a fertility check following their treatment. It's also worth noting that some of the treatments can result in early menopause, which for a young girl can be really challenging. And also just to highlight the haematological cancer treatments require irradiated blood products for the rest of their lives.
So we can't really talk about young people without talking about communication style, and adapting to this is really key to successful interactions with young people at all stages, from primary care to tertiary care and into surveillance and long-term follow-up. A lot of expectations are placed on young people to communicate as adults. They often look like adults. We expect them to make adult decisions and plan like adults. But young people are still developing all those cognition skills, from concrete to abstract thinking. So we need to think about our approach to young people. Our colleagues in Wales have produced this piece of work with a youth advisory group, which is developing a guide for principles of communication. And there's some leaflets on your tables if you want to take those away with you. How do we improve the outlook for young people? So we know that diagnostic timeliness is multifactorial, with complex interplay of patient, professional and healthcare systems, not all of which are fully understood. There's a real wide variety of diagnostic routes across cancer types, and some differences in diagnostic routes by gender as well. There's a clear need for targeted awareness campaigns to reduce patient lag time from presenting symptoms to diagnosis, and there's further education, as always, and training required in this area. However, evidence does show that even with our patient cancer awareness campaigns, whilst it improves symptom awareness for the young person, it didn't necessarily change the health-seeking behaviour, possibly because of fear, embarrassment and priorities of that age range. NICE guidelines, and one of the main key points which comes from that in terms of early diagnosis is if a young person is coming back to you in primary care with unresolved symptoms, with repeated presentations, they should be treated seriously, and young people really know their own bodies. Local cancer networks should have agreed, implemented two-way pathways of care, and that's within primary care, but then also within the cancer site-specific pathways. And more research is required for interventions that mitigate any adverse impacts of prolonged diagnostic intervals.
So here you can see a variety of local and national support services. Some are specifically aimed for teenagers and young adults. The support here ranges from education to social and peer support, counselling, physical activity and financial support. You can also see at the bottom there's a survey there which we've just been asked to highlight. This is an ongoing national cancer survey for under 16s looking into their experience of cancer. So thanks very much for listening. Does anyone have any questions?
Lovely. Thank you so much for coming today for that really interesting presentation. Obviously, young adults with cancer isn't very common. It's not something many GPs are going to come across in their working lifetime. Just have you got any advice or suggestions you'd give for people who this isn't their day-to-day practice? It might not be something they've seen before.
Thanks, Suzanne. Yeah, I think highlighted in the talk really as well, it's about really listening to those young people, and if their young people really know their bodies, and if they're presenting numerous times, then there is something wrong, whether that's cancer or something else. But I think key is something that Phoebe said on the video, is about seeing the same GP. I think young people find that really helpful, and it builds up trust and those therapeutic relationships with them as well. So again, you know, it is small numbers, as you've said. It's maybe 1 or 2 young people that you might see in your whole career, but it could mean the difference between them having a better outcome or not.
Okay, so today has been designed to be really informal. We want lots of interaction, lots of questions. We've built plenty of time into the agenda as well. So I'm going to go check, see if anybody online has asked us any questions, but otherwise, are there any in the room from anybody at the moment? Got the roving mic. No, I think you've stunned everyone in silence. Lovely. I'll just go check if there's any online for you. So we've just got the one comment on the chat, which is all the leaflets that you've put on the table. Is there any way to put those online or link those out?
Yeah, we
Yeah.
can do that. Yeah.
Brilliant. And is there anything you'd like to say about the service we run here in Greater Manchester? Anything about how GPs can get in touch, or link in if they've got any concerns or any young patients they want to discuss with you guys?
Thanks. I would say probably the best way to go about that is because the principal treatment centre is the Christie Hospital. If you go onto their website, there is a specific section on teenage and young adult services. There'll be some generic numbers that you can find on there. I would always be happy to take phone calls, and I'm sure Lindsay would as well, if primary care teams were musing over certain patients, that they could get in touch with us, and we can offer some informal advice that way.
Brilliant. And then the last point I was thinking when I was watching the video from Phoebe is how similar it was to Liam's story as well, who was just another sort of younger aged adult as well. About, in retrospect, it's so easy for us to sit here and say, well, actually, by the time they got to A&E, here was this really long list of really classical symptoms these patients were coming with. How could we miss this? Whereas actually, when you start digging back, it's, you know, a bit of this and a bit of that. And they are quite non-specific, those symptoms. So I can understand the diagnostic challenge. For all of our primary care colleagues, on our 2-week wait referral form, at the top, there's a particular section for young TYA type patients, and it says very, very clearly if there's any concerns about these specific symptoms, and one of those is easy bruising, in a young adult, could we please get a blood test very quickly within 24 to 48 hours, not 2 to 4 weeks, just so we're not missing these patients. So the guidance is there for anybody who wants it. It's on our 2-week wait referral form around testing.
Thank you, Sam.
Thank you. Thank you, guys. Okay, so we're going to move on with the agenda. We're going to stick